This is part 2 of musculoskeletal conditions, and we will be looking at AMC, or arthrogryposis, and some of the related conditions, such as club hand, club foot, that are associated with arthrogryposis, AMC. So as we've known, we've covered AMC somewhat in PBL. And so we know that arthrogryposis, or arthrogryposis multiplex congenita, comprises non-progressive conditions characterized by having a multiple set of joint contractures found throughout the body at birth. They think that it may be caused due to decreased fetal movements, which could be caused by either muscle or connective tissue disorders, having an inability to move around. In other words, maybe a short umbilical cord so there's less movement, being crowded by having multiple babies in utero. There may be a connection to maternal infections, drug abuse, or specific trauma may also contribute to decreased fetal movements. This lack of movement actually causes extra connective tissue to form, resulting in fixation of joints. So, in other words, if you don't use it, you lose it. What basically happens is if you don't move, your body will actually form connective tissue, or that kind of acts like scar tissue basically, and scars down, so those joints don't move as well, which then would result in that fixation of the joint or contracture. I was kind of surprised that the frequency of arthrogryposis is 1 in 3,000 births, and so it is not that uncommon. In practice, I don't recall anybody having the diagnosis of arthrogryposis, but I do remember having students or individuals, clients, who had bilateral club foot, bilateral club hand, or so having those frequent and multiple types of contractures and those sorts of things. So kind of ironic they didn't have the AMC diagnosis, so I don't know if it just was unnoticed or if it literally didn't exist. Both males and females are equally affected, and the lifespan depends on the severity of the disease. So if the spine is compromised, it could literally affect the spinal cord or central nervous system. It could also result in affecting the pulmonary system. Again, if that pulmonary system is affected, you're going to have trouble breathing, which could result in that shorter lifespan. If you remember back from your PBL, it can be detected with an ultrasound in utero. So they can take a look at some of the joints. They can see if there are abnormalities, joint contractures, decreased fetal movement, those kinds of things with that ultrasound. So once a child's born, OT treatment may include serial casting. So maybe you're trying to cast those contractures to try and alleviate that imbalance of flexors, extensors. Maybe it would be as simple as a splint. You may do active range of motion, passive range of motion. You may educate somebody on doing active range of motion, passive range of motion, and stretching as a home program, because you just can't continue to do passive range of motion every day in your therapy sessions without some kind of functional gain. When we look at contractures, say we have wrist flexion, our flexors are in their tightened position and our extensors are in the lengthened position. And so what we're doing with splinting, casting, stretching is we're trying to lengthen the flexors, and we're trying to shorten the extensors. And so that ultimately would help that joint capsule stretch also, and kind of reverse that contracture. Unfortunately, surgical intervention is quite common and may certainly be required to um, lengthen the flexors and shorten the extensors as well. Perhaps there's some orthopedic things that they may need to do. Since it is affecting connective tissue, they may actually have to surgically go in and connect or disconnect some of that extra connective tissue or remove some of that extra tissue. And then that's when your active range of motion, passive range of motion, and stretching is also really important, because after any surgery, you may have scar tissue that's forming rapidly. And so in order to do that passive range of motion and stretching to prevent that scar tissue from adhering down and further contribute to that contracture would be important. Let's see here. Contractures in the feet. This is actually club foot, which we'll talk about shortly in the future. And so you see this part is elongated and this part is shortened here. You also see how tightly these fingers are contracted and how they're interwoven even with each other. And so we know that there would be joint damage or a potential for joint damage. We see hyperextension of the DIPs here. And then of course with the fingers flexed, again your flexors in your forearm are in that shortened position, and in your extensors in the forearm are in that lengthened position. And so we would have that muscle imbalance. Congenital club foot is talipes equinovarus. And so the incidence is quite common, 1 to 2 per 1,000 births. They do say it's more common in boys or siblings with the condition. And so it can affect either one foot or both foot. They don't know the particular cause, but they're speculating that it could be due to in utero crowding. It could be a baby's foot gets stuck in the mother's ribs and doesn't have the ability to move. And so it sort of is stretching out one side where the other side is again in that shortened position. And then as that baby continues to grow, that muscle imbalance grows in that condition or in that position. I did have a cousin who had a baby with bilateral club feet, and I'll kind of refer to that as we move forward. But they think the cause of her baby was just a small uterus, and so again decreased movement. They felt like his feet were unable to move and get free of something, and so and she had prior issues since there wasn't a lot of room in her uterus. Her first baby actually passed away because the baby got hung up in the umbilical cord and those sorts of things. And so that baby didn't make it. The second baby had bilateral clubfoot, and then the third baby, actually, there was no issues. Everything was fine. So hopefully that uterus, I'm guessing, has sort of stretched and grown from multiple childbirth. As you can kind of go back and see the picture of that little baby, you see that the forefoot is actually in an adduction position as well as supination. The heel is actually turned inward, which is called a varus, and the ankle is actually an equinus, which means that the upward bending is somewhat limited. You also see some medial deviation of the foot. And again, this could be because the bones are malformed or underdeveloped, maybe because of that prolonged position in utero, those sorts of things. A lot of things that could play a part of that. Rare paralysis or rare permanent deformity can occur, but again, it is fairly rare. It is actually quite commonly fixed. Again, here's a picture of clubfoot, and so we see that adduction and supination of the forefoot. We see that the heel is turned inward, and there's very limited bending of that ankle because of that particular position. So medical management, also OT management. Taping is something that could be done, just again to kind of place the foot back into alignment. Maybe there's splinting that would occur. Very commonly, there's serial casting, and so sometimes that's done by an OT, sometimes that's done by somebody else. Serial casting, there's a video here on casting clubfoot, those sorts of things. Prognosis is good and best when treated very early. And so typically it's done in the first week of life. And if it's done later, there may be permanent ligament issues and permanent contractures. So when that baby's first born in that first week of life, things are still very malleable, right? The soft tissue is malleable, the bones are very soft, and so they can kind of be placed back into that position, and the prognosis would be pretty good. With serial casting for clubfoot, typically they will cast the individual for about 2 to 3 months, and then they'll slowly change those casts every week. And so again, trying to slowly move that position of that ankle to where it should be. We want to consider also in treatment just the developmental aspects. And so is there any mobility issues, looking at gross motor skills? You know, when do children typically walk? You know, did they have surgery before, or did they have surgery at that first week of life right away, or did they have serial casting? And so are they then delayed with their gross motor skills? Again, you can look at it just past surgery, where you may just be doing, or immediately after surgery, where you may be recommending different types of positioning, whether it's positioning in a crib, positioning in a stroller, because it's going to be kind of awkward with those casts on. Looking at activities of daily living, maybe how does teaching a parent how to do diaper changes with those clunky casts, or is there any orthopedic considerations or precautions with positioning or with ADLs, such as bathing? So you may have to look at alternative ways to do that. Now, as the child, again, post-surgery or post-casting, is there anything that we can do to facilitate development if there is a delay? You know, my particular cousin that I think of, her child had surgery and casting, so a combination of both, very early in life. And then once they were removed, they had some physical therapy to kind of do range of motion with the ankles, to kind of work on some of the pre-walking things, and ambulation. They didn't need OT. Certainly we could have played a part in that as well. But her little boy started walking right at 12 months, and so there really wasn't a delay. He healed very quickly from surgery, and it didn't affect his development with gross motor, and he's just completely unaffected to this day. So here's a picture of casting. Again, you're just slowly trying to put those ankles and hips and knees into the right position. Again, looking at just some precautions of, you know, there's even some redness in the groin here, so there could be some issues with diaper changing, there could be some skin issues, integrity issues, those kinds of things. And so again, I've seen just where the clubfoot has been casted and slowly progressed to normal, which would be, you know, lengthening the affected side and shortening the unaffected side, to prevent and to correct that soft tissue imbalance. And then I have seen where there have been surgery and then casting in that position as well. And here's a picture after casting, and so you can see, and in that sort of flex position. The ankles are flexed kind of in that neutral position and very typical. Club hand is far less common, and this is where you have partial or full absence of the radius, or there's bowing of the ulnar shaft. And so you'll have sort of that radial deviation. So it may look like there's a radial deviation. And so it's caused by either an underdeveloped absence of the radius muscles, nerves, and or arteries, or again, it can be orthopedic in nature. Ironically, the hand often remains functional. That's kind of what I found in the literature. OT treatment may look at, again, just increasing that active range of motion with that hand, bilateral hand skills, passive range of motion, again, so the wrist doesn't adhere and basically scar down in that position. You may look at some static or dynamic splinting. Certain types of ADL training or school training, maybe some adapted things with writing, buttoning, zipping, eating utensils, those sorts of things. Surgical intervention is less common with club hand versus club foot, and they say it's more for a cosmetic benefit. I'm thinking of one individual I worked with club hand, and we actually did, he had very, very weak radial muscles, meaning he couldn't, raise his thumb or lift his thumb to give a thumbs up, which when you look at cutting, when you look at grip, when you look at a lot of those functional things, that was very hard for him. And so we worked to try and increase the radial muscle strength. We did some soft Binnick hand splinting, kind of a thumb spica to give that thumb more stability. And then we worked on a lot of bilateral hand skills. And so it affected his right hand, and he just automatically became left hand dominant. And he didn't want to use that right hand at all because it was hard. But as he grew, we had to work out on those bilateral hand tasks, right? You still need that thumb extension and DIP flexion when you're looking at grabbing certain things like paper, when you go to cut with the scissors, or doing buttons. So you still need that non-dominant hand when doing those bilateral tasks. And he never did have surgery. It was fine. And again, since it was his unaffected side, his non-dominant side, we just had to really work on those bilateral hand skills. And so that's it for club foot, club hand, and arthrogryposis. Thank you.